Hi, all. Thank you for joining. We will get started in a few minutes as we allow people to sign on. All, we are just waiting for a few of our panelists to join. If you can give us a few minutes, we'll get started momentarily. Thank you all for joining our first webinar of 2023. We're excited to kick off the series again and continue on our work that we did in 2022. I'm Miriam Khan. I lead communications for Gradient Health Systems and want to thank you again for joining us today. I will turn it over to our moderator, Dr. Ndaba, to get us started with introductions, and I will then take it over to just give a quick overview on some of the housekeeping updates for the webinar. So Dr. Ndaba, I'll turn it over to you for intros.
Thank you very much, Mariam. Good morning, good afternoon, good evening, everyone, wherever you've logged in from. We would like to welcome you to this very important discussion. Today, we are discussing everything preoperative. So we've got two presenters. We have Dr. Anna Doho, physician anesthetist from Tanzania. And then we also have Dr. Saleh Murutu, a physician anesthetist from Tanzania as well. And then we have three panelists myself, Dr. Spokandava. I'm a physician anesthetist from Lusaka, Zambia. We also have Dr. Papicho Ntambwe, who is also a physician anesthetist from Zambia. And lastly, but not the least, we have Dr. Sweetbet Ndebea, a physician anesthetist from Tanzania. So we would like to encourage participation as much as possible. We have provisions at the bottom of your screen where you can send in your comments, contributions, or any questions that you may have to ask. So at this point, I'll hand it over to Mariam for some housekeeping rules. After that, I'll come back with the objectives of today's session. Mariam, over to you.
Great, thank you so much. So just a quick overview. If you have any questions during the webinar, you can use the Q&A feature to ask us, and there will be a Q&A session at the end of the webinar. The webinar will be recorded, so you will receive a copy of the webinar following the completion of it, and it'll also live on our website, and you'll see the address there at gradienthealth.org. And then lastly, if you have any feedback or want to share any topics you'd like covered, please feel free to reach out at customers@gradienthealth.org. We'd always like to hear from you on any suggestions you have to make this webinar series even more helpful. I'll turn it back to Dr. Ndaba to go through some of our objectives.
Thank you so much once again, Mariam. So like I mentioned earlier, today we are discussing all things preoperative preparation for anesthesia and surgery. As you may be aware, this topic is quite extensive. So we've just selected a few objectives to highlight some of the critical areas of the preoperative period. So we are going to discuss the preoperative preparation of the patient for anesthesia and surgery. And then we'll discuss some of the steps that we take as we prepare or pre-assess patients for surgery. And then we'll also spend some time to talk about assessment of anesthesia and surgical risks. As you are aware, there are various assessment tools or assessment methods to assess the risk of anesthesia or surgery in a patient. But we'll focus more on the most common ones, which is the ASA, the cardiac risk scoring, and the exercise tolerance, and a few more. We'll also proceed to discuss airway assessment. As you are aware, airway assessment is one of the most important aspects of preoperative assessment. We'll also discuss investigations. What are some of the investigations that you need to consider for a patient who is undergoing surgery? At this point, we would also like to hear your experiences, because we understand that we have different protocols in our different institutions. So we are glad to actually get your experience on the investigations and what sort of protocols that you are using. Then we'll go further to discuss briefly on the preoperative medications that you might want to consider. And then we'll touch a bit on some of the causes of surgical cancellations in the preoperative period, and also would invite discussions on how best we can reduce on surgical cancellations. And then we'll end by discussing some of the best practices for patient safety, drug handling during anesthesia, because this is also part of the preparation for anesthesia. So these are the few objectives that we will try and that will guide our discussion in this session. But again, we want to encourage more participation, more experience sharing, because this is something that we do in our routine practices. Without much ado, I'll immediately invite our first presenter, who will take us through the first part of the presentation. And this is Dr. Anna Doho from Tanzania. Dr. Anna, are you there? Can you hear me?
Yes, I can hear you, Ndaba.
Okay, no, thank you so much. The platform is all yours. Please, you can start.
Thank you. Good morning, good afternoon, and good evening to every one of you. As I've been introduced, and I'll take you through the first part of this presentation, which is more on a pre-operative preparation for anesthesia and surgery. As you all know that pre-operative preparation for anesthesia and surgery is crucial in determining operative outcomes in surgical patients. That is to say, this is a fundamental process in patient safety, of which failure to perform it effectively, it will lead to the increase of poor perioperative outcomes and endangering patient safety. The American Society of Anesthesiologists, preoperative patient preparation is a key step in the prevention of anesthesia-related mortality and morbidity. However, there are key processes in preoperative preparation, and these processes are a must to go through and to undertake. These are the most important processes, and one of them is pre-anesthetic evaluations, in an essence that before taking patients into theaters for surgery and anesthesia, we really need to do a thorough and effective evaluations for their fitness, if they can undertake and tolerate anesthesia and surgery itself. And the second process is optimizations of the patients. What do we optimize? We need to optimize any medical conditions that the patients are having, such as chronic diseases like diabetic mellitus, hypertension, and again, the medications they are using. And on top of that, some patients mean weight. Post-operative care is the most important one. So having said so, we need to understand and consider that the pre-operative period is the most crucial period in determining surgical outcomes. Next, please. So in preoperative period, there are a number of activities that we need to undertake. And the first one is surgical booking. Booking patients for surgery, the day of surgery, and then what surgery is to be done. And patients need to be aware of when his or her surgery is going to be done. And the second activity is communication and consultation. This is to say that we need to communicate between departments involving physicians, anesthesiologists, the surgeons, the physiotherapists, and also the nutritionists concerning general condition of the patient before considering surgery and anesthesia. And the pre-anesthetic evaluation, as I have explained before, it's an important activity and it is a must to be done. The next is risk stratification. So assessing the risk pertaining to the particular surgery for the individualizing our patients and including the general conditions, the risk that they may anticipate during and after surgery, and the planning of the whole process of surgery and anesthesia itself, in optimization, as I explained before, and resource mobilization. When we talk of resource mobilization, it's basically it's what we have in terms of manpower, the staff. Do we have enough staff? Who should take care of which patient at what time, intra-op and post-operatively? And do we have a place where we can nurse our patients Do we need to nurse them in ICU? Do we have enough resources such as medications, monitors, and staff who needs to be around for patients? And then the last but not the least, informed consent. So we need to obtain informed consent for surgery, for anesthesia, and also for blood transfusion. Next slide. So pre-anesthetic evaluation is an important and integral part of pre-operative preparation for anesthesia and surgery. Why is this so important? It is an opportunity to identify comorbidities that have been there and the comorbidities that are newly diagnosed to our patients. These comorbidities or the medication that our patients are using for the conditions may also lead to complications during anesthesia, during surgery, or during postoperative period. As for example, if the patients have hypertension, some of medications do interact with anesthetics. So some of them needs to be stopped before surgery, or consideration of switching the medications that the patients are using for hypertension to other group of antihypertensive is paramount, and this is done during pre-anesthetic evaluations. Sometimes we have surgeries which are easy to perform. They look simple, but anesthesia is of greater risk. So we really need to evaluate our patients effectively and thoroughly to rule out any risk that may endanger patient safety during anesthesia provision. So wherever we have patients who are undergoing any procedure, whether they need sedation or they need anesthesia, it is a must that they undergo pre-anesthetic evaluation. Considering this fact, most of patients who are having anesthesia outside operating theaters, such as those who are going for MRI, they need sedation. But in most of our settings, most of patients will just come from home, they are coming for MRI, of which the evaluation was not done. But the ones who are handling the procedure, they just notice that these patients cannot undergo surgery, cannot undergo procedure without sedation. So they will just call for sedation. I will advise that the patients need to be evaluated, even if it is on table or on that day of the particular procedure. Next. So there are a number of studies that have reported the rate of mortality regarding anesthesia. It is not 100% safe that we can really provide anesthesia. As I said, anesthesia itself is of greater risk and it can endanger someone's life. There are mortalities that have been reported, and 1/3 of deaths have been said that they are preventable. The cause, why do we end up getting mortalities because of anesthesia? There are a number of reasons, but the most frequent one is inadequate patient preparation. So if we cannot prepare our patient very well, we have to be sure that we can endanger their lives in our licenses. Remember, nowadays we have law that is undertaking patient safety. So inadequate patient preparation, I would say, can lead to a practice of medical errors. And another cause is inadequate postoperative management, whereby we don't have enough resources, is term of human resources, equipment-wise, and space as well. Wrong choice of anesthesia technique is another cause of mortality relating to anesthesia. So we get patients who were supposed to have regional anesthesia, but we end up giving them general anesthesia, of which can also endanger their life depending on the individual circumstances that the patient is having. And another cause is inadequate crisis management. Most of us are not really ready to manage crisis events that occurs during intra-op or post-operative, or even sometimes pre-operatively. This is due to resource limits that we have. Sometimes we don't have medications, and sometimes we don't have equipment such as a working laryngoscope, or sometimes the working suctioning machines. Sometimes the availability of prepared equipment is a problem. We really need to undertake preparations as a serious entity when it comes to the point of anesthesia and surgery. Next slide. Why do we care about preoperative evaluation? We have goals. We have goals to achieve. And the first goal is risk stratification. If we assess risks, then we can minimize the rate of mortality and morbidities regarding anesthesia and surgery itself. We need to plan our surgeries, plan the timings, plan the medications, plan the resources that we need to use during particular surgery. Of most important, the informed consent. We need to obtain informed and written consent, consent for surgery, consent for anesthesia, and consent for blood transfusion. And this has to be done by a team, meaning that anesthesia team, surgeons, and the nurses who will be taking care of that particular patient. Patient needs to know why he or she should undergo what procedure, and that procedure, how is it going to be handled? Then intraoperatively, what is going to happen, what to expect? Post-operatively, what to expect? Is patient going to be nursed in ICU? Is patient going to be nursed in HDU or in general ward? And then when it comes to the point of blood transfusion, some of the procedures need blood transfusion, of which most of our patients, some are Jehovah's Witness, of which they will not accept to be transfused. That's pain. So we really need to make a clear understanding to our patients when it comes to point of informed consent. When we talk of optimization, as I said, we need to optimize any medical condition, any new incident or findings to our patients. And sometimes optimization may end up with either cancellation of the risk of the surgery or delay the surgery. Resource mobilization, I've explained a bit, and consultation or communication. There is a problem between surgeons and anesthesia team when it comes to the point of communication. We really don't mingle when it comes to patients cancellation or patients for further investigations. Sometimes it's not really smooth communication. So I will urge or advise that communication is the key when it comes to patient safety. When we're doing procedure between surgeon and anesthesiologist, there should be a closed loop communication, a smooth communication concerning the ongoing patient's condition and operation. Preoperative evaluations improve surgical outcomes. This comes all through preparations of what I've mentioned earlier. Next slide. Is there a specific time for pre-op evaluation? There are a lot of variabilities when it comes to timings for preoperative evaluations. It depends on the nature of surgery, if the surgery is emergency or an elective. For emergency cases, preoperative evaluation should start as soon as the surgery is declared and agreed in terms of communication and consultations. Because if we have an emergency, from emergency department, there should be a communication from surgeons to anesthesia, and then amongst anesthesia surgeons and nurses or theater team who will need to prepare for that particular patient. When it comes to elective case, it depends. Are we doing pre-op evaluation on the day of surgery? But the most common one that we normally use is pre-op evaluation the day before surgery. But however, we can have a pre-op evaluation done a week before surgery and weeks before surgery. In some countries, they have evaluation done even months before surgery. So it all depends in our institutions, in our centers, and local protocols that we have for concerning surgeries and evaluation. Anesthesia clinic is of importance, but in our country, to some places, it's not routinely done. So I'll urge and emphasize that anesthesia clinic may reduce the rate of cancellations during the day of surgery, and it may also improve mortality and morbidity in considerations to patient safety. Next. So when it comes to pre-anesthetic evaluations, there are a number of steps that we routinely follow. And I must confess that history taking, examination, and investigations in anesthesia are focused. It's not the same as like you're taking history from patient who is in internal medicine, in general surgery. When it comes to anesthesia, the history has to be focused. And when it comes to point of history, we all know it always starts with demographic details like the name of the patient, the gender, the age, the address. That's important to us because anesthesia technique that is going to be used is also different. The details of surgical diagnosis, like what is the diagnosis and what is going to be done, what is the procedure, the reviews of the other system, what do we review? Reviewing other conditions that the patient might not have mentioned. And the past history in anesthesia, we consider if the patient has had a previous exposure to surgery, whether the patient has had problems during previous anesthesia exposure, whether this is repeat or this is a first time to be exposed in anesthesia. Medical history, what medical conditions the patient has. Another history which is important is drug history. Is the patient on any medications? Is there any allergies, any known drug or food allergies? Then social history, we need to consider is if the patient is taking alcohol and how much and for how long. And when the patient, if the patient is smoking, how many cigarettes per day, how many packs? And then we need to advise them on the importance of cessation. When it comes to examinations, we really need to focus on general condition of the patients, from nutritional status, considering obesity, overweight, or the patient is in normal condition, a normal health status, whether the patient is jaundiced, not jaundiced, is pale or not pale. If there are obvious things that can be seen, considering congenital anomalies and some of the acquired anomalies, and then vital signs. These are very important. Checking pulse rate, heart rate, blood pressures, temperatures, and assessing the respiratory rates. And the most important one and the most crucial of which, if will not do it is considered as a sin. It's an airway assessment. It's a very, very important because there's no way you can provide anesthesia without touching part of the airway. Then we have systemic exam. You examine the systems from central nervous system, respiratory system, cardiovascular system, GI, genitourinary, and musculoskeletal system. When it comes to point of investigations, there are different protocols which exist depending on the institutions and the local protocols, but it is important for every one of us to understand that each test that has been ordered is relevant to particular condition at hand. Is there any relevance? Do I just ask investigation routinely to every patient? So that is important to understand why we should order which investigation. Next slide, please. We talked of risk stratifications. So here it's risk assessment, it's just the same point. Is it important? Why is it important to assess risk in surgical patients? So it is very, very important, and it's a mandatory to do risk assessment in surgical patients because this will ensure the safety of patients if they can tolerate anesthesia for the planned surgery. It can also enhance a new plan of clinical optimization and planning for post-operative care, and that mainly include post-operative pain management in the place or the proper place where the patient can be nursed post-operatively. And a risk assessment will minimize morbidity in our settings during surgery and even during post-operative handling. Next slide. We said when we deal with risk assessment, there are things that we should focus on, which is the first one is ASA classifications of physical status, and we had cardiovascular risk index assessment, and then we have physiological and operative factors that we need to assess the physical fitness for the patients who will undergo surgery. So considering ASA classifications, I hope everyone knows what ASA classifications are. We have ASA 1, 2 through 6, and then we have a mnemonic E, which is a suffix that stands for emergency operation that is added to a group or a class of ASA that we name our patient to. We have ASA 1, which is a normal health individual who is coming for surgery only. And the mortality for ASA 1 is 0.1, as you can see. For ASA 2 patients, the patients with mild systemic conditions, but these patients or their disease is being controlled, and the mortality is 0.2. Class 3, these are patients with uncontrolled these systemic diseases, but these systemic diseases are not incapacitating their life, daily life movements. Mortality rate is 1.8. Class 4, it's a patient with incapacitating systemic diseases in a constant threat to life. And mortality here is high, about 7.8. Class 5 is a moribund patient who is not expected to survive 24 hours with or without operations, and mortality is high. As at 6, the organ donor patients, and if you add the suffix E in front of any class that stands as an emergency surgery. Now I have a question. Do we have ASA 1 emergency? I don't need anyone of you to answer me right now, but I would like to know it later on. Moving to another factor considered in risk assessment is cardiovascular risk index assessment. We have Lee's revised cardiac risk index. This is a parameter that assesses the fitness concerning cardiovascular system in patients who are undergoing non-cardiac surgeries. It assesses if the patients can undergo cardiovascular complications when he or she is undergoing non-cardiac surgery. Then another factor is physiological factors and operative factors, the so-called POSAM. This assesses the risk of perioperatic mortality and morbidity. These factors are physiological, including age in years. Do we have pediatric patients or we have geriatric, the age extremes? The cardiac status, is the patient stable in cardiovascular body, is the patient stable in chronic systolic, is the patient within normal range, or it is the range is concerned. The blood workup from hemoglobin, the white blood cell count, the biochemistry, and then the ECG rhythms physiologically needs to be assessed for us to ensure that we are not at the risk of anticipating any anesthesia-related mortality or morbidity. Then operative factors, the type of surgery. Is it a complex surgery? Do we have multiple procedures? What is the expected blood loss? Do we have any peritoneal contamination? What is the surgery? So it comes to risk assessment. Next slide. Next slide. This slide. So again, we're still in a risk assessment. This is again on the cardiovascular risk assessment. The surgery that is considered high risk, low risk, or intermediate risk as far as the cardiac is concerned, as follows. So some of the surgeries, especially those who are undergoing non-cardiac surgery, but the patient has undergone myocardial infarction and had any surgeries among will be expected of high risk depending on the urgency and the need of that particular surgery. So we have low risk surgery less than 1%, intermediate risk 1 to 5%, and high risk, which is mainly involving the major vascular surgeries, peripheral vascular surgeries. So we need to consider for us to prepare our patients thoroughly and avoid the risk of mortality that is related to anesthesia and surgery itself. Next, please. So we have a metabolic equivalence. Metabolic equivalence mainly measures patient's functional capacity, and it may mainly, it simply explains on energy expenditure when someone is at rest or when someone is doing any physical activity. So it basically explains how a person is consuming oxygen, and when the person is at rest, we have one metabolic equivalent, which equates to 3.5 mils of oxygen per kg per minute when at rest. And a patient's functional capacity will predict the patient's outcome, perioperative complications, and it will indicate the need for further evaluation. So a person, a normal met points will usually be normal when it comes to 5 and above, but less than 5 and below will be a risk to a patient because the patient may not be fit for surgery or may not handle or tolerate the anesthesia. So a patient may need to be optimized regarding of his physical fitness for the surgery. Next. So these are the graphs of groups which explains and expands mainly on the metabolic equivalence, the functional capacity for a particular patient. So as the number increases, the more fit the patient becomes. On the right side of my screen, we see metabolic equivalence, and we see exercises and recreations and the work that a person is doing. And this will regards to cardiovascular metabolic equivalence. So as I said, metabolic equivalence of 5 to 6 is good, and because this is good because it enhances the energy consumption in terms of kilocalories that are within our bodies. So the more we use energy, the more fit we become. How is this even our concern? It is our concern because for younger ones, the pregnant mothers, we know that there is an increase in oxygen consumption. So if we all know this, then it will be important for us to prepare our patients pre-operatively concerning their functional capacity. Next. Next slide. Why is the airway examination important? Why do we care about airway? So airway assessment or airway examination is important to us because it will assist us in predicting if we can mask ventilate our patients and if we can intubate our patients for mechanical ventilation during anesthesia or even after surgery. It is very important for us to assess airway so that we can prepare when we anticipate difficult airway. We get ready for managing difficult airway in terms of ventilation, in terms of technique, in terms of equipment, in terms of skilled personnel. So when we anticipate difficult airway, in terms of whether ventilation or intubation, we really need someone skilled, and we really need equipment such as video laryngoscope. We need personnel who may undertake or who may take over when it comes in the situation of can't ventilate. For some of the conditions, there may be no access to the airway before operation. So they need surgical airway first, such as tracheostomies, before we induce them to surgery and anesthesia. So it's really good to do airway assessment and get ready for any difficulties. failed mask ventilations happens. There is no any insurance that I cannot fail because I'm an anesthesiologist, because I'm senior, because I'm whatever. But when it comes to the airway, we really need to be very humble and respectful to the airway. Then we have 4 areas where we need to assess. Can we mask ventilate? So we really need to know if we can ventilate by the mask. Can we do laryngoscopy and intubate? Is it going to be easy to use LMA, laryngeal mask airway? Will it be easy to insert? Is the patient fit for LMA? Difficult in tracheal access. Sometimes you may have patients have anterior masses, patients may have stiff neck joints, and it will be here. So we really need to prepare our personnel and equipment. Next. How do we assess airway? So we say usually it starts with the history from the patient. Take the history. If the patient has had previous incidents regarding airway, if the patient has trauma on the airway, so it's good to know what happened to the patients regarding airway. And then any other clinical circumstances should be considered. So most of patients who have undergone trauma, mainly the cervical spine injury, those who have had rheumatoid arthritis, congenital diseases such as Crohn's, we really need to know if one of these is within our patients. So sometimes patients may not really tell you about the cervical spine trauma, or it's just congenital anomaly that the patient is on the way he looks or the way she looks. Then part of rheumatoid arthritis, we need to do some assessment. Is our prayer sign. We usually put our hands together and as we pray. So we really need to assess these conditions, and this, if the joints have been stiff in the hands, then it's likely that even in the cervical spine, the joints are stiff. When it comes to difficult intubation, patients usually get hypoxia very, very fast. So when we anticipate any difficulty, then it's better we get ready to manage, knowing in our mind that if we fail to intubate, then we need to ventilate for us to prevent our patient from hypoxia. This happens mainly to pregnant mothers and in children and in obese patients and those who are aseptic. So we really need to act very fast. Next slide. So as I said, with physical examination, we really need to be sure whether patient has any congenital anomaly or there is an acquired condition such as burn injury on the face, the masses, the obvious mass on the face or the oral cavity. So we really need to assess them just by looking. And it's important for us to be aware of anatomical variations that exist between patients. So when assessing or when examining our patients, we really need to see on the obvious acquired problems, any anatomical features, any mechanical deformities, poor dentition. We need to ask about the teeth. Is there anyone with the loose teeth, the one who is wearing dentures? Because sometimes those with facial hair may present with difficult mask ventilation. And then positioning and mobility of the larynx and the trachea, is it centrally located? Is there any deviation of the trachea? We really need to assess. And then is there a way that we can access to cricothyroid membrane when it comes to a need of a surgical airway? Can we really access the cricothyroid membrane? Next. So these are a number of factors, and with the examples that I've mentioned, which can be inherited, that is congenital or developmental problems. In pediatrics, mostly the condition that can present with difficulties in airway management will be Pierre-Robin syndrome, Down syndrome, and acquired problems can be gross obesity. So the obese patient, we need to do something when positioning. Rheumatoid arthritis, ankylosing spondylitis, the acromegaly, then surgical neck fusions, and patients who have undergone radiations. So we really need to be sure of what is happening with the patient. And there are problems due to surgical conditions, the arthroplasties, cervical surgeries, fascial burns, and laryngeal surgeries may also increase the risk of difficulties when managing the airway. So before we take patients for anesthesia, we really need to be sure of these presentations. So previous problems with anesthetics, again, noted difficulties, dental damage or severe sore throat with previous anesthesia. So these are just things we need to really consider when it comes to the airway assessment. Next. There are components of the airway examination. However, there are positive tests in only infrequent followed by true difficulty. But the sensitivity and specificity of the test is lower in practice than in original papers that report the test. So with this slide, I would say we cannot really say that this is difficult and we are sensitive, that we are specific, that this is difficult airway. Sometimes the assessment that we do helps us or guides us in a way that we get prepared if we find or if we get into a difficulty airway management. Next slide. Next slide, please. So when it comes to the point of airway assessment or where airway examinations, we have specific tests. I will group them into a mnemonic, one mnemonic that will summarize all of these tests. To start with, we have lemon mnemonic. I'm sure you have once heard of the word mnemonic, with the mnemonic lemon in capital letter. So L stands for a look, that is just by inspection. You just inspect the patient just by looking. And when you see, E is mainly for evaluations. We have 3-3-2 rule, which will involve thyromental distance, 3 fingers or more than 6 centimeters. And the second 3 is interincisor distance, which is interincisor gap, which has to be that the patient has to be able to accommodate his or her 3 fingers in its mouth between the incisors, and it has to be more than 6 centimeters, which is normal. And we have 2, which is thyroid it has to accommodate the 2 fingers, which is normally it has to be more than 4 centimeters. We have other tests like protrusion of the mandible. The patient has to be able to protrude the mandible. And the forward movement of the mandible. Another one is Malampati classification, which is mainly assesses oropharyngeal space in relation to the tongue, for us to be able to have adequate mouth opening and doing a laryngoscopy and endotracheal intubation. So with Malampati, you have class 1 to class 4, where you visualize the structures as it's seen in this picture. And as class 1 and class 2, a normal airway where we don't anticipate any difficulty, but class 3 and class 4, we anticipate difficulty. So when we anticipate difficult airway, we get ready. But sometimes you can have as class 1 and class 2, yet you anticipate difficult laryngoscopy and intubation. We have obstructions if there is any mass in the face, any mass in the mouth, any tumors that can enhance difficult intubation. We have neck flexion and extension, that is the movement, the neck mobility, assessing the cervicospine motion. Without forgetting teeth, we need to know if the patient has loose teeth, if the trachea is deviated anyhow. And then we don't have to forget to check the chest X-ray, although it's not a routine, but when you anticipate any difficulty, you will really need to do chest X-ray. Next. So I think that marked the end of my presentation. I would like to handle this time to Ndaba.
Thank you so much, Anna, for that very wonderful presentation. So I will not delay, but to proceed and ask Dr. Saleh to pick it up from here and run us through the next couple of slides before we open it up for questions, comments, and sharing of experiences. Dr. Saleh, are you?
Hello, Ndaba. How are you?
Fine,
Hello,
thank
Ndaba.
you.
How are you?
Thank you, fine. The floor is yours. You can please continue.
Okay, thank you very much. Good evening, good morning. Hello, everyone. My name is Saleh Mrutu. I'm an anesthesiologist. I work with Muhimbili in Dar es Salaam, Tanzania. So Anna has covered a lot of ground in terms of pre-anesthetic or pre-operative evaluation. So I'm just going straight forward and discuss. So after doing your history taking, physical exam, then there's another component of patient evaluation, which involve pre-operative investigations. So one question that usually come along when it comes to pre-operative evaluation is pre-operative testing indicating for every patient. So should every patient be given a document that should go for pre-operative investigation? So that's the question. I hope everyone will think about it, and then maybe we can have some answers as we go along with the presentation. But as you can see for the cartoon there, so this mama is in a pre-anesthetic clinic, and then the mama is asking, just for anesthesia fitness, I need to do all the blood report, ECG, chest X-ray, 2D echo. Isn't there a simpler way? And then the doctor just say like, Yes, there is. If you can run today marathon, you are fit for anesthesia. So I think with this analogy here from this cartoon, you can agree with me with a presentation from Dr. Anna. She talks something about MET score, metabolic equivalent score. So they say if you need additional tests, if you have a score less than 5. So if you can run a marathon, means that you have a score more than 5, probably more than 12. So probably you won't need additional tests if you can run a marathon. And there's a poster there down there that says city marathon today. So that's a good analogy. However, but why do we do this test? So one way it could be to screen for the disease process. And this will be guided from your history taking and physical exam. So sometimes the surgeons, they usually concentrate on the surgical disease itself. So patient come with a fracture, so they only see the fracture. They forget to usually analyze the patient as a whole. So during the preoperative evaluation, the anesthetist should go through the full evaluation of the patient, and Anna insisted that you should be a focused history, and you can pick something from your history and physical exam. So your investigation could be a way of proving if there is that problem that you pick from the preoperative evaluation in terms of physical exam and history talking. But also the main purpose of preoperative evaluation, number one, is to make sure, is this patient fit to be given to undergo surgery, or is this patient physiologically fit to be given anesthesia? We know our patient, when they are given anesthesia or they undergo surgery, they what is called the physiological response to surgery and the physiological stress response to anesthesia. Can this patient handle this stress? So physiological. So one way is to evaluate fitness from the patient. But as I said from the previous, that this should be based on what you find on history and propose the physical examination. So the answer for the question above, that no, preoperative testing is not indicated for every patient. So whatever you put in your checklist there, the patient should do as a preoperative investigation, this should have a very specific indication why you are doing it, and you should be able to defend. Let's say you order a full blood picture. So if the full blood picture, what do you want to look? So I want to look the HB. So let's say the HB comes 9. What are you going to do? Will it affect your decision making in terms of surgery? Will it make you change your technique for anesthesia? Will you make you add for additional investigation? So the thinking should be like that. And sometimes the more tests usually cause more anxiety from the patient and costs, and then maybe cause delay for surgery without any specific reason. Next slide, please. So when should preoperative tests be ordered? So preoperative testing should be ordered if the result will impact the decision of the planned procedure. I think that as I talked about it in the previous slide, that whatever you order must have an implication in terms of your management. So the common investigation that we usually order, it's a full blood picture. Okay, fine, you ordered a full blood picture. What do you want to look? So I want to look for the HB. Okay, fine. So if the HB comes 10, how is it going to affect your planned surgical procedure? If the HB comes 9, what if it's 7? How is it going to change your procedure? I want platelets. Okay, so what is your cutoff point? And if it's below than that, will it affect anything in your planned surgical procedure? Will it need you to alter your anesthetic plan, or will you need to add additional support to support this patient? So you must have a specific indication why we are ordering the investigation. We just don't order just for the sake of it, like, it's a routine, let's just do it. Order some creatinine and urea, it's just a routine investigation. So will it impact your anesthetic plan? So that's a very important question you should ask yourself. Another thing is based on what patient has on history and physical exam. So like I said before, sometimes the surgeon, they tend to overlook things and they're just concerned with the surgical condition itself. They forgot other things to ask the patient. So in your history and physical exam, one of the components that we ask on the history is the review of other systems. Are there other system that is affected apart from only the surgical illness? So sometimes you might find the patient has increased dyspnea on exertion, or they have some chest pain that usually get worse with movement, also has some episode of syncope during the night, or they tend to snore at night. So is that important? Does it need you to do other additional investigation? So probably yes. So probably if a patient has exertion dyspnea, maybe you want to do more cardiac exam, like do maybe on the chest, more the echo, or maybe an EKG to see what's going on. Maybe the patient has a chest pain. You might need to do that. Or you just put your pulse ox, or you are listening to the heartbeat. You see the rhythm is not regular. Patient usually maybe skips a bit or has variation on the heart rate. So maybe you might need to have additional investigation for that. So your history will guide you what to order. So tests are ordered to establish diagnosis. So if you think that maybe there's a new something that was not discovered, so you might need to order for that. And sometimes worsening of medical condition. So there are patients who have comorbidities, which will be picked from the history. So if this patient has a comorbidity, maybe he has hypertension for a couple of years, does this hypertension worsen for over time? So some of the tests can be used to evaluate for worsening of medical conditions. So the patient maybe has chronic kidney disease. So that has been there for maybe past 5 years, has been changed for over the couple of years. So sometimes you might need to do tests for that. And then can guide us in terms of decision making and manage the patient with severe comorbidities. I think Anna talked of issue of optimization. So through testing, through history, physical exam and testing, we can use the test available to say, probably, maybe this patient, we did a full blood picture, the HB is 7, but we have an elective procedure. Probably we can do something before going for the surgery. Or you do a certain investigation, you find this patient, maybe you do an echo, maybe the ejection fraction is lower in the lower zone, means the heart failure is not controlled probably, or is a new heart failure onset. Can we do something before going for surgery? Or if the patient is now an emergency case, there's no room for postponing the case. So can we do something to make him better while going for surgery? So decision-making and management of patients with comorbidities through investigation will guide us to do that. So these are the why we need to do these tests actually. Let's go to the next slide. So this is one of the table that is there from one of the famous anesthesia book. Give you just a bit of a hint, like if you want to do a full bed picture, what kind of patients you should think about. So if you have this patient, maybe you can do a full blood picture. If you have this kind of patient, maybe you can do a urine creatinine and electrolyte. You have this kind of patient, you need to do liver function test. So sometimes when you see a patient in your pre-anesthetic evaluation, be it anesthesia clinic, be it a day before surgery, or be it few minutes or few hours before the surgery for emergency cases, you should think which investigation will be specific for this patient. So probably full blood picture. So sometimes some of the patient might only need an HB for that. Some of them you need to have a complete full blood picture. Some of them might need a full blood picture plus ABO. Some of them need a liver function test. So when you have a health man, maybe 20 years, come maybe for a hernia repair, you might need a few investigation compared to a pregnant lady with preeclampsia, now come for an emergency cesarean section because of severe feature of preeclampsia, and probably she has fitted once. So the investigation that you're going to order for this lady, you will be different, probably different from this one. So this is one of the table that is there in the anesthesia book. So probably maybe if you look at the blood glucose, it's fit only for patients to have diabetics and vascular diseases. So other people, maybe you might not need to do that a glucose test or HbA1c percentage. ECG, maybe you might need it to do for patients with evidence of heart problems, like chronic hypertension, heart failure, or rhythm problems. And sometimes it has been shown that we tend to order ECG for certain kind of age patients, like maybe this patient is an elderly, so let's get an ECG. So the study has been shown that probably you might not have, the ECG has no utility if you are only relying on the age aspect. But the ECG might be very important in terms of altering your anesthetic plan and utility in determining of adverse event in terms of cardiovascular if there's associated or picked heart problem during the physical and exam. And sometimes you might need to do an X-ray based on patient presentation, like if patient has respiratory disease, chronic respiratory disease, like COPDs and stuff like that, or has any lung pathology, you might need to have do a chest X-ray. So this table just say which patient will fit for which investigation. Just one caution, the first line urinalysis for all patients. So that was kind of an old thinking. So now the urinalysis has been shown that routine urinalysis is not indicated for every patient. However, you can do it for pregnant women and patient who has evidence of urinary tract infection during your pre-anesthetic evaluation. You can go for the next slide. So this also same, just give you an overview of what, which patient will be fit to do what investigation, like complete blood count, maybe for major surgery, neonates, more than 70, female than 45, anemia, malignancies. So some of the patient might not need a complete full blood picture, HB will be enough. Some of them will need maybe a complete full blood picture plus an ABO with a holding. Sometimes you might need even to do cross match. And this is the common question I usually ask my students, like, do you know the difference of adding an ABO plus an ABO and cross match? So ordering an ABO and cross match means you need to know the blood group of your patient, plus you need this patient to be, you need to prepare blood for this patient for transfusion. But sometimes we realize most of our patients, they don't require transfusion for their surgery, because their surgery, maybe they are minor to moderate, and then the blood loss is not expected to exceed more than 500 mils. So sometimes we should be very cautious with what investigation to what patient there we order for them. And just another caution, these are the table that we obtain them from the textbooks. So sometimes there might be changes in terms of which investigation. So what I should urge you guys, you should always know which patient you are seeing and what probably investigation you might need to do. And there are always reference around to look around. So maybe I'm seeing a patient, elderly, 70 years old, he's diabetic, he uncontrolled, he's hypertensive, uncontrolled, he probably has issue of reduced urine output. So which investigation will be good for them? You can do just quick reference, and then we can have a very good decision making in terms of investigation. And this investigation should also have an implication. What management will change in terms of those investigations should audit. And this, Anna, I think she has stressed as well, the communication. So one of the common misunderstandings between surgeons and anesthetists is when it's come to investigations. Say like, oh, this patient has never done an ECG. So I want an ECG. Without an ECG, I cannot put this patient to sleep. So you need to go an extra mile and tell the surgeon or that person, like, I need an ECG because I think this patient has breathing problem. And then with breathing problem, if I put this patient under anesthesia, the risk of cardiovascular adverse event, intraoperative and post-surgery will be this much. If I found 1, 2, 3, I might give this drug, or we might give this drug to make this patient better, and then we'll have him or her for anesthesia. Just throwing an investigation blanketly without giving these people a reason, this will be a big part for dispute between surgeons and anesthesia. So I urge you, my anesthesia fellows and other perioperative care providers, when we order investigations, you must have a basis why you order investigation, and then you must have a plan if this investigation come A, B, or X. Next slide, please. So some of these are just general terms, like what is the minimum recommended investigation for before anesthesia for a patient who has, maybe you're going for out of out of operating theater procedure, like giving maybe a CT with a contrast, maybe an angio. So if there's any way you need to give contrast to this patient, maybe you need to do a creatinine levels, because we know these dyes, they're going to be extracted to the kidney. So it's good to know the creatinine. And this creatinine should be within 3 months. So if the patient has done a creatinine level within 3 months, there's no need to add an additional test. Hemoglobin should be checked if the surgery has potential significant blood loss, and the type 1 screening should be obtained if there's a likelihood of transfusion. I think these I just spoke in the previous slides. Like if you order an ABO and a cross match, you should think kwamba your patient is going to do an ABO and the patient will pay also for cross match. And then the lab will prepare a unit of blood for you. So if you don't need that blood, means first the patient has contributed to a cost that is unnecessary, and then there will be a blood that will be reserved for that patient who does not need. And sometimes there might be a patient in need and will be denied of that blood just because you wrote an ABO and cross match. So you should do a cross match if you really think the patient require transfusion. And this will be graded, depends on the type of surgery the patient is going. Is it a minor or a major surgery, or underlying hemoglobin of the patient, if this is an emergency case and stuff like that. So an ECG is indicated if the patient has active cardiac conditions such as decompensated heart failure, arrhythmia, chest pain. I think I've talked it in the previous slides. And 1 day surgery may be useful to obtain potassium level. This is for a patient who has chronic kidney disease. And there are also guidelines. So you get a potassium in the morning or a day before surgery, and the potassium should be like this. And if the potassium is not in that level, they will tell you, this patient should go dialysis a couple of hours before surgery. So this is why we build, because if the potassium is this level, then you completely change our management plan. So maybe the patient needs to go for dialysis before going for surgery, stuff like that. Patient with DM, diabetes mellitus, might need to do glucose level or HbA1c, which is it's good to tell you the diabetic control for the past 3 months. Probably the hemoglobin glucose level itself won't be enough at that moment. So you need to do maybe a glucose level and HbA1c percentage. And we usually balance between the risk and benefits of the procedure with abnormality of the test. So that's the same question I usually ask people. So you want a full blood picture, the HB comes now. Now, this patient, what will be your decision making in terms of that? And this should be balanced between the risk and benefits of doing the surgery. So if the benefits will be prolong the surgery, if it's an elective surgery, maybe you might need to prolong the surgery. But if there's a risk of this disease process going to be worsening, then you need to weigh what you found in your test and what will be benefited to the patient in terms of investigations. Next slide. So that's it's all about the investigation. So that's one thing that I should really stress between you guys. When you order investigations, make sure you know what you order and what's important to be, what information you get from those investigations and how it's going to change your management. And this should be shared through all the surgical team, the perioperative care team, in order to avoid the quarrels and misunderstanding between the team. And we just like anesthesia, they like to cancel patients. No, it should not be that way. So we should go at least an extra mile explaining to them the importance of what investigation we usually order. So then the investigation has been ordered. We say this patient, okay, it's either this patient is fit for surgery or the patient is not fit for surgery. If the patient is fit for surgery, then we proceed for surgery. If the patient is not fit for surgery, is there something that we can do to make this patient better in order to go for surgery? So that's something also is missing, especially when most of our practice, we usually don't share with our colleagues like, this patient is not fit now for surgery. So what can we do to make it him or her better? I think Dr. Anna talked about the issue of optimization. That's when we say, what can we do to make this patient better? Can we make it better today or tomorrow? Or we can make it for a few months and stuff like that. And then if the patient will proceed, they say this patient is good for surgery, then there are issue of giving the developing anesthesia plan. And your anesthesia plan usually start with what is called the pre-operative medication, or the common terminology usually used, they call pre-medications. And there are different reasons why we give pre-medications. One of them is control the metabolic of medical conditions. So some of the patients, they have a certain medical conditions. We might need to give them drugs before surgery in order to make them better on the day before surgery. And others, so some of the patients, they might have anxiety problem, like they are very fearful of the surgery and stuff like that. We might need to think them, giving them some anxiolytics to make them better. There's preemptive analgesia. I think this is a common concept in anesthesia practice. We have preemptive analgesia. We usually give patients analgesic medication before going to surgery and then induction of anesthesia. Drying airway, prevention of autonomic reflex response during induction or during intubation, reduction of gastric fluid volume. This comes for those patients who are coming for an emergency surgery. We know they have never been fasted for a couple of hours. Even if they fast, as long as the emergency usually considers them as full stomach. So we can give some of the drug to usually reduce the gastric content volume. And there are some antiemetic for those patients who has increased the risk of nausea and vomiting, or this patient who has issues of unfasted patients. Reduction of anesthetic requirement has been shown. Preemptive analgesia, like giving them analgesia a couple of minutes or hours before surgery, will reduce the amount of anesthesia that you use during induction. Some of the pre-medication, they usually given for smooth induction, and for some patients who have allergic reaction, we usually give them prophylactic to prevent an allergic reaction. So these are the reasons why we give medication before induction of anesthesia or before operation. And usually these drugs, they have a limited time. There's time that when you give, you say this, the time that you're given pre-operative medication. So this usually they're given 20 minutes to 3 hours before induction of anesthesia. So the time will be good for giving pre-medication. Giving pre-medication during the induction time might not be very good for some of the medication, because some of the medications they need to pick up before actually it can give a desired effect during induction. So you should know which pre-medication are you going to give, what's the reason are you going to give that pre-medication, and what's the time should be given before the induction or before the surgery itself, so as you can have a desired effect that you want. Next slide, please. So this one I said, like anesthetic management usually begins with psychological preparation and medication if necessary. The psychological preparation is usually talking about make sure the patient is psychologically safe, or you trying to take care of the psychological component of our patient. I think this will be discussed further in the next slide, in coming slides. But when the anesthetic management, usually we take care of psychology, we give psychological support for the patient, for the relative, and then sometimes if medication necessary, we can give the medication to these patients for several reasons that we have seen before. So pharmacological action of the drug should always be kept in mind. This means the timing of the drug, when should you give the drug so as to have the desired effect. And satisfactory pre-op preparation will facilitate an eventful pre-operative course. I think this Anna covered it very well. The reason why we do pre-operative evaluation, why we do investigation, why we do the physical exam, and then comes the preparation of the patient, why we give pre-operative medications, why do we give psychological support. All of this, they'll have an impact on your pre-operative practice. So like I said, there's no a wholesale. One of my teachers used to say, don't treat patients as wholesale, like one shoe fit for all. So there's, even after this presentation, no one will tell you the consensus, like each patient should give 1, 2, 3, 4, 5. So there's no consensus will exist in choice of preoperative medications. So I have different medications that are there, and usually depends on your preoperative evaluation. Some of the medication will be fitted for the patient. Sometimes you might not be doing medication at all. But the major point in anesthesia, we want to put this patient are free of anxiety. I think we'll discuss more in the next slide. Next slide, please. So there's a part of psychological preparation. So this also is one of the major goals of why we see our patients before anesthesia. So we should talk to our patient, either themselves or together with the families, especially when you are taking care of pediatric patients. You should think about the family members well. If now your child is going to a certain major operation, they're going to be given certain types of drug for anesthesia, there might be some worrying around there. And if the mom, or the studies have been shown, especially when you take care of pediatric, if the mother or the father or the caretaker is worried, even the child will be worried and the anxiety level will go up, and then you'll have a lot of challenges with your anesthesia management. So you need to explain to your patient or the caretaker or the family member the whole process of anesthesia. Remember, this is not the part of you explaining about the surgery, because that should have been done by a surgeon. If that was never done, and the patient kindly asks you about that, you should say like, okay, I think your doctor or the surgeon have better answers than me in this area. For now, let's talk about the anesthesia management. So your explanation should actually be based on your anesthesia plan. You need to explain the whole process. If you're going for GA, give everything. I'm going to give you drug. You're going to come to the operating theater. We're going to put a line. We're going to give you some drugs. You're going to sleep. After you sleep, you're going to put a breathing tube on you. You want to be able to breathe on your own. We'll assist you with the breathing, stuff like that. So you need to take them through the whole process of anesthesia, any complication that might happen during the surgery. What have you prepared with managing those complications, and if there's any alternative technique that you can use. And this has been shown that if patients, they are aware what's going to happen to them, the level of anxiety usually goes down, and usually have a better perioperative outcome for these patients. And through this, you need to build the trust and confidence for your patient. So talk to them, build the trust, and they will trust you, and they'll be confident with you if you know your stuff. And the only way of showing them that you know what you're doing and you're prepared to take care of them during this difficult time of your life is explaining them each step of the way. And information should be informative, comforting, and if possible, you might need to give some anxiolytic medication and stuff like that. So the issue of emergency situation, emergency surgery. So sometimes we need also to give room for this patient to hear their concerns, even if it's an emergency surgery. It will help you along the way for these patients. So next slide, please. So pharmacological preparation might be required for certain kind of patients. So every patient should be individualized. And sometimes you might not have an ideal drug to cover everything that you all need for your pre-operative medication. So it should be specific for each patient. If this patient is anxious, talk to them, give them the psychological support. If the psychological support didn't help, and you've tried your level best to explain everything, then there's a room of giving them anxiolytics to calm them down. But sometimes only psychological support is enough. So probably this patient is an emergency, unfasted patients, intestinal obstructions and stuff like that. You might need maybe to give something to prevent emesis. You might need to give anti-acid medications to reduce the acidity of the gastric content. And sometimes you need to give H2 blockers to reduce the amount of hydrochloric acid production. So always it's patients is specific to the patient you are seeing at the moment, being it an elective, being it an emergency, and what are the concerns from the patient. So like I said, patient physiological preparation, physical status, age type, and duration of surgery must be considered while you are thinking all these processes. Next slide, please. So these are some of the medication. There are a lot of medication that you can give as a pre-medication. Depends with the concept that we've talked in the previous slide, like psychological status of the patient, age of the patient, type of the procedure, are there any comorbidities for these patients? So there are some of the patient, like maybe I'll give an example, like an asthmatic patient who he has been kept on bronchodilators to control his or her asthma, might require to be given a short-acting beta bronchodilator or beta agonist before induction of anesthesia. But that's not required for other kind of people. So it's usually patient specific. So this list is not exhaustive, but these are some of the drugs that we can use, like midazolam, lorazepam. These are usually used for anxiolytics or sedation for patients, to calm them down, to keep them calm, to avoid any anxiety. We have fentanyl, morphine, meperidine. This can be used as part of preemptive analgesia, giving patient medication before actually causing the pain itself. And some of the patients, they might be in pain even before going for surgery. One of our center here at Muhimbili, they usually do operation for patients with radicular pain, orthopedic surgery. So these are the patients who are going for surgery because they have severe pain. They need to go for surgery to do some surgical intervention in order to relieve that kind of pain. So these are the patients that they might need pain control even before going for surgery. Issues like that. So you have omeprazole. These are for patient, maybe you think the patient has, these are for emergency patients, unfancied patient, might think of giving them ondansetron for MSS. Atropine and glycopyrrolate, these are usually given to dry the secretions. And metoclopramide, these are prokinetics. Usually, these are the ones that use it to reduce the volume of the gastric contact. Bear in mind, all the drugs, they have a time of action. So you should think, you should know, if I'm giving atropine, how long should I give before surgery? If I'm going to give maybe an anxiolytic, so for anxiolysis, maybe you need to give them at least 1 to 2 hours before operation or before induction for it to give the effects that you want. But if you give an anxiolytic maybe immediately at that moment, you might not need the effect that you actually need. So you should know the time factor for this. And there is antibiotics, we usually give them also as a preoperative medication, and we know that antibiotics need to give 30 minutes before surgery. So if you give them together with the induction phase, at the time of induction, you know the effect will be maybe as adequate as intended. So you should know your time when to give this preoperative medication and which patient should benefit from your preoperative medication. Next slide, please. So now comes the this has been the challenge for perioperative care, theater case cancellations. So let's go to the next slide and see this issue. So this has been a problem in terms of perioperative care for patients, for both anesthesia provider, theater team, the hospital management, and everything. So usually you have financial cost in terms of cancellation. So maybe today you have planned your theater is going to operate 3 people. You have already booked the room for 3 people. And then at the end of the day, 2 of them, they are canceled. 1 of them need to wait at least for optimization. So at the end of the day, you'll see your table will remain empty. No one will be operated for a couple of hours. Maybe the 3rd one has been told you to fasted in the morning of the day of surgery because you thought that patient is going to be last, but now the 2 patients, they're not fit for surgery, they've already been canceled, and then you need to wait for a couple of hours, probably 6 hours for this last person to come to theater. So all that time when the theater is not used, you are losing money and you are waste resource. There will be people there and they're not doing anything, just have fun and stuff like that. But also in terms of patient, it causes social and emotional problem for the patient. So the patient has been fasted, has been planned for surgery, the surgery has been paid and stuff like that. And now at the end of the day, you're telling them, no, we cannot do surgery for you today, maybe tomorrow, maybe the day after that. So it's a social and emotional problem for patients. And in developing countries where healthcare is challenging, so the cancellation does even worse, it tends to worsen the system because you have limited resources and you have a huge pool of patients. So when you go to our ward, sometimes you have patients stay in the ward for 2 weeks just to wait to be put in the operating list. And then now the time comes is ready to be kept on the operating list, cancellation happens. So all this time, it will bring more patients, so the load becomes bigger, more patients are waiting for surgery and things are not happening. So it's important to minimize cancellation, and this has a multifactorial issues. It's not just one person that can affect the cancellation. It has system effect, the provider themselves, the patient themselves, and sometimes there are unintended events, like maybe you have already optimized your patient, everything is good. The next morning, the patient develops a fever. You do your blood test, the patient has developed infection overnight, because sometimes we are human beings. We don't know when we're going to get sick. So sometimes these things are multifactorial. And it's important to make sure that this help reduces the economic of loss in large hospitals and patient and in nation at all. Next slide, please. So in this slide, you actually see some of the things that will impact in surgical cancellation. It's not just anesthesia provider, it's not just a surgeon, it's not just the facility. So there's a lot of things that can happen to cause the patient cancellation. So one, some of the patients, they might refuse to give a certain consent. So probably maybe you have a major surgery, you know, you have maximum, you're going to have what is called a major hemorrhage. You need to maybe to activate a major transfusion protocol because of the surgery itself. Then the patient say, like, I'm a Jehovah Witness, I cannot consent to being transfused blood. And we know in our system, we don't have a mechanism to harvest the blood itself during surgery. So sometimes you are backed in a corner, the patient refuses to give consent for that. Sometimes we give this patient instruction, especially when we are dealing with this pediatric patient. So you actually give the mama good instruction, like the patient should be fasted for this couple of hours because of 1, 2, 3, 4, 5. And then very early in the morning, the baby starts crying because of hunger and thirsty. And the mama decide to give him maybe a chai or an andazi or something. So at the end of the day, the patient might not be fit for surgery at that moment. And sometimes as anesthesia provider, we usually don't give clear instruction for these people. So in our textbook, it's written, if you're taking a heavy meal, it's 8 hours before induction. If you're taking a light meal, 6 hours before induction. If you're taking whole breast milk for the one that still sucking breast milk, it's 4 hours before induction. If you're taking clear food, it's 2 hours. But these people, they don't understand 8 hours. Is that clear? They don't understand 8 hours. So it should be very specific. So mama, you're going to take this, what are you going to eat? I'm going to eat 1, 2, 3. So because of this meal that you're going to eat, you should calculate your 6 hours. You should calculate your 8 hours, 2 hours. So tell these people specifically, from this time of night, you should stop eating this kind of food. From this time of night, you should stop drinking clear water. Telling them like 6 hours, you should stop eating. They don't know what 6 hours it is. You are the one who knows 6 hours. Sometimes patient can die while waiting for the procedure. Case can be aborted in the operating theater. And sometimes for those patients who are being admitted more for a day before surgery, sometimes they might just decide not to come for operation. Yeah, maybe things might happen at home and then they fail to show up for the operation. In terms of facilities, the equipment might not be there available. You come in the morning, you check your anesthesia machine, your anesthesia machine is not working. So we know we cannot do anything if there's no anesthesia machine. Even if you're giving spinal, you should be able to, even if you're giving regional techniques, you should be able to provide general anesthesia. Sometimes you might come to the operating theater, the machine is not functioning. So that could be one of the reasons. So that's facility issues. Some of the areas, they might require some imaging to do. The imaging is not functioning, so it might be cancellation. Implant is not there, especially here at one of our center at Muhimbili Orthopedic Institute. We do a lot of implants. So we come in the morning, the implants, they are not there. So there's nothing we can do. The implants, they're not there, and the patient needs this implant if we want to give a successful outcome. No ICU bed, so this is one issue, but this usually comes to the issue of prior planning. So if you know your patient is going to need an ICU bed, you should book an ICU bed very early to make sure that you have a room for this, to put this patient in the ICU. But sometimes emergencies do happen. You might book an ICU room for your patient. At the end of the day, an emergency came, all the ICU beds are filled, and then you cannot do anything. So there's issue of no hour at time. Sometimes you might plan a lot of elective cases, and then an emergency happens. So we have a huge trauma center here at Muhimbili. So we can have an accident happen. We need to take care of a lot of trauma patients. They need surgical intervention. So it might cancel the elective cases to do the trauma patients. So we have issues of abnormal result, change of treatment plan, change of medical status. This is just what I said. You might have a normal patient today, but tomorrow comes, the patient developed the fever, or the patient started diarrheaing overnight, or vomiting, persistent vomiting overnight. So some of the patients, they might change procedure. Anesthesia issues, we have drugs issues. So sometimes there are certain kind of patient might need to have a certain type of medication. That medication is not there. So it's become unsafe to anesthetize this patient. And sometimes there's issue of fatigue for our healthcare providers. So have an unrealistic list, operating list. So this comes off an issue of planning. So you have a theater, you have 6 patients coming for surgery. All of them, they're major surgery. So sometimes the issue of fatigue and burnout, which can cause cancellations. Next slide, please. All right, so we have seen issues of cancellation in all areas. So the aim here for us showing you this list, although it's not an exhaustive list, and there's a study which will be done this year at Muhimbili to look the reason for cancellation for our patients. We might come off more exhaustive list, and when you go to the articles and review literatures, you'll see there's more reason for cancellation. The only way is try to minimize this cancellation reasons, which comes planning, good communication, and budgeting of our perioperative care practice. So there's issue of safe drug handling. So let's go to the next slide. So we know as anesthesia is a complex profession. We assume responsibility for our patients. So we usually change this patient to be normal patient to critically ill patient by just giving them the medication we are giving. So this patient, they trust us with their lives. So we assume responsibility for patient well-being. And at the same time, we have lethal drugs that we can give to patient and cause them harm at any time. So sometimes it's not easy to predict whatever thing that we are pushed to the patient. And so some of the drugs have an idiosyncratic reaction, and other factors may contribute to the issues of drug handling, like inadequate patient preparation and anticipation as anesthesia providers. Next slide. So to make sure what we are giving for our patient is safe in terms of drug handling, make sure we have adequate preoperative preparation for our patients. So some of the patients, we know propofol is a very common drug. It's a very good drug that we are using for our daily anesthesia practice, but that could be a killing drug for some kind of patient. If you don't do your preoperative evaluation very well, that's usually propofol that you usually use every now and then could kill this patient just because this patient is not good to give propofol. So adequate preoperative preparation, adequate history taking in terms of the issue of allergies and issues like that, they can happen in theater. This patient can go complete anaphylactic shock, anaphylactic reaction, cardiac arrest, just because you didn't take your time to take a thorough history, and then you push a drug that you usually push for other patients, and this patient end up in cardiac arrest. Adequate examination and preparation for patient. So this is when the argument comes between surgeons on anesthesia. And so some of the patients, they might have a surgical indication, but they are not fit to be done surgery today. They might be ready for a couple of weeks or months to come, but not today. So we need to prepare this patient to be ready to receive anesthesia and to undergo surgery. And you also need to have appropriate planning of anesthesia for each patient. So there's no wholesale while you're treating patient. There's no one shoe fit all. So each patient should be treated differently. And that's why we do a preoperative evaluation, investigation, and optimization. So each patient should get different. So there's no such thing as everyone should get propofol, everyone should get ketamine, everyone should get Suxa. If your practice is like that, it's still dangerous. So you should optimize and know which patient you should give which type of drug. Next slide, please. So how to reach safe drug handling? So modern anesthesia practice would rely on giving multiple drugs. So if you come in my operating theater one day, if you get to visit, you might find I have a whole tray with maybe 10 drugs at once. So all these drugs that we usually give in anesthesia practice, they usually have different potent, different routes, and they might have different response depending on which kind of patient. So you need to have local standard operating procedures to make sure safe storage of these drugs. So some of the drugs, they have issues of using as eliciting drugs, especially the opioids. So we should also, so it's not always about the patient safety, it's also the safety of us as providers. So some of the drugs have potential being used as eliciting drug, addictions, and sometimes they may even cause death to us ourselves as provider. So there must be standard operating procedures to make sure this handling of medications, which can be dangerous to both patients and and ourselves, there should be anesthetic should identify which drug there must be immediately required at the moment, and limit access for some of the drugs that they might have potential for causing unintended infection for both patients and ourselves. Next slide, please. So with that being said, a lot of information has been thrown to you. So in summary, the preoperative period is the most crucial phase of surgical care, and it determines the surgical outcome. So this message should be across to every perioperative physician, from surgeons, anesthesia provider, and the other non-physician perioperative providers like nurses and other urgent staff. Like, preoperative period is very important. It should be done for every patient, regardless this patient is elective or an emergency, because it has a lot of importance, like the one we have just discussed since this presentation started. So pre-anesthetic assessment is the fundamental principle of surgical patient safety. So for those who are mostly vigilant and enthusiastic in terms of patient safety, one of the patient safety measures to do pre-anesthetic evaluation. Anesthetic and surgical risk assessment is essential, and this will affect your planning for anesthesia, planning for surgery, and even the post-operative care for our patients. Preoperative testing is a key for anesthesia and surgical care. It's, however, important to understand the relevance of each test that is required. Please underline those words. Like, they're important to do investigations, but you should know what you are ordering and why are you ordering, and how that, if you find the result this much, how is that going to affect your plan? So this will be the end of the presentation. I will turn back to the moderator to continue for questions, clarifications, and other informations. Thank you very much.
Thank you so much, Dr. Saleh, for that very wonderful, audible and clear presentation. And also thank you so much, Dr. Anna, for the earlier presentations as well. Just as we conclude our session today, let me just quickly recognize the presence of senior anesthetic colleagues. This includes General Obashina, senior critical care specialist from Nigeria, We have Dr. Dafadzwa from Zimbabwe, who is the president of the Association of Anesthetists of Zimbabwe. We also have Dr. Lugazia, who is the president of the Society of Anesthetists of Tanzania, as well as several other senior anesthetists present on the call. Thank you so much for joining us. At this point, I would like to pause and ask if there are any questions or any clarifications or any comments, and indeed any experiences that any one of us on the call would like to share. As we just raise up your hand or unmute your microphone and go ahead and speak, since we don't have so many hands. Anyone who is ready and available, please feel free to have a go.
Well, thank you so much, Ndaba. And I think I should thank the presenter for a nice presentation. As they said, well, this was a marathon. They've covered a lot of ground, but it's an important concepts and a part of the safe anesthesia provision. However, this maybe you might need to prepare another session. We all know that COVID-19 hit us hard, and it was a multi-systemic disease. So right now, post-COVID-19, we need to keep that in mind. Those who are severely affected by COVID-19 had multi-system dysfunctions that carry over even after they've recovered. So during the preoperative assessment, we should stress to find out if any of the patients that we are dealing with suffered COVID-19, and then go an extra mile to evaluate the organs or the system that could have been affected, or they still have the residual effect from the pathophysiology of this deadly disease. So I think I thought I should mention that, but it might be helpful if the audience agree that we need to have another session that might look at how do we deal with those people with the post-COVID-19 syndrome. Thank you so much.
Thank you so much, Dr. Lugazi. I think that's a very interesting aspect of the discussion. And I totally agree with you that we really have to have these conversations of COVID as it has actually affected, the clinical dynamics for most of us practicing right now. Any further comments or questions? I can't see any hands raised. Anyone ready? Kindly unmute and you can have a go as we conclude this session in the next 2 or 3 minutes. Yeah, so may I ask General Obashina if he has any comments to make? Yes, you can go ahead.
Hello.
Okay. Hello. Yes, we can hear you, sir.
Okay, me, I don't have a question, but I have something of experience. I was working in Somalia before, and then the context of safety of anesthesia in that country is very low. In that situation, there was no anesthesia machine, or there was no even oxygen. There was just oxygen concentrators. Hello.
Hello, we can hear you, sir. You can carry on.
Okay, now most of the cases of eclampsia in that situation, I could not get an anesthesia machine. So what I did in that field, I usually give labetalol 20 milligram, and then give ketamine. And it did very well in most of the patients because I did it there from 2014 to 2022. And I've never seen mortality in eclampsia. Even reversal was good. The patient recovered. That's all I have.
Thank you so much for that experience and sharing that very intriguing experience. I think that just sort of gives us an idea of how much work we have to do in terms of anesthesia and critical care in Africa. There's so much capacity building that needs to be done. And I think this is just an initiative towards helping or assisting our colleagues in terms of improving anesthesia capacity in respective countries. Yeah, so thank you so much for sharing that experience. I'll allow one last comment from anyone before we close the session today. Hello?
Hello?
Okay, you're allowed, sir. You can go ahead.
Hello?
Hello, we can hear you. You can proceed.
This is Tindi, Dr. Tindi Mwewa from Uganda. Are you getting me?
Yes, we can hear you very loud and clear.
The retired anesthesiologist who trained so many, still going on, by the way, training. I really appreciate your inputs as far as CME is concerned. So keep it up, and thank you very much.
Thank you so much for that comment. We really appreciate the praise. So I can't see any further hands up at this point. And as we conclude, I would like to invite Mariam to give us any final comments, as well as Magdalena to just close the session for us. Mariam, it's over to you. Thank you.
Great. Thank you to our presenters and thank you to our moderator. I'll just conclude by saying the recording of the webinar will be available on our website, gradienthealth.org. And again, if you have any questions or comments, feel free to email us at customers@gradienthealth.org. I will turn it over to my colleague Magdalena now just to give us a quick closeout, and we look forward to seeing you at our next webinar.
Thank you very much. I wouldn't add so much. Mine is just to thank you. And as usual, building our anesthesia and critical care network, you're invited to visit our website and see the machines that we have. We have the UAM, we have now the Prima, we have the ICV, which is a new ventilator that has many modes as compared to the CCV. We also are looking forward to bringing in the KO2 for oxygen therapy and oxygen access in our markets. Thank you very much. And by the way, all this come with a training. We have very good trainers in our team. And thank you so much for joining in. Looking forward to another webinar. Have a nice time.
Thank you so much. Bye-bye for now.